what I did was to talk about some of the more chronic pain syndromes in children. Acute pain management is very similar to adults. The dosing is actually a little different per kilo and based on age and weight. I didn't feel that that was quite so important. So we're going to talk about chronic pain syndromes in children. To start with, talk a little bit about the development of the central nervous system, and then talk a little bit about pain measurement tools, which are different in children than in adults, and then a bit about pharmacokinetics and pharmacodynamics, particularly in the neonate, where it gets very different than in the adult. Sorry, I did this. So about 20 to 24 weeks of gestation, we start to see thalamocortical synapses develop. Subthalamic myelination starts at about 30 weeks, and the thalamocortical projections are there by 37 weeks, which is a full-term baby, right? Just a little, where is that? No, where's the top of the slide? I did this on evidently a different version of PowerPoint than they have here. So these are definitions that you need to know if they use these terms. A neonate is somebody less than a month of age, so less than 30 days is considered neonate. Infant is a child 1 month to 1 year of age, and then a child is anybody greater than a year of age. We know that nociceptors are present in the skin of the neonate. That's the A delta and the C fibers. They grow out from the dorsal root ganglia. They innervate proximodistally. C fiber maturation is delayed. There's incomplete peripheral myelinization, probably until about age 4 to 6. And the descending, which are the inhibitory cortical pathways, are delayed in development. Now we know that the descending pathways modulate spinal nociceptive neurons, okay, and can modulate the input to the central nervous system of a painful stimulus. So what does this mean? It means that you have an endogenous analgesic system that's lacking in the newborn, okay?
Is that why they're always crying about everything?
That's why they're crying about everything. It's true, you see? Need to know a little bit about spinal cord anatomy. It's different. By the 3rd fetal month, the spinal cord fills the entire canal. At birth, the conus is at L3, and if you compare that to the adult, where the conus is at L1 or L2. And there should be a picture. There we go. So you see the white thing is in the spinal cord. At conception, it's around there. It's all the way down, and then it goes up. This patient gets older. Morning. Talk a little bit about reporting tools. You know, the titles didn't come out on this. Yeah. So there's things like poker chip tools for children, FACES scale you're probably familiar with, visual analog you can use in older children, the Oucher scale, and I'll show you a picture of that. I don't think we really use that too much around here. Maybe it's a good thing to get for some of our patients. And then finally, in the older children, adolescents, a pain diary is possible. Okay. Neonates and children, there's something called the Children's Hospital of Eastern Ontario Pain Score, and I'll show that to you in a minute, which has 6 items that you make a scoring system. Younger children, you can use a visual analog or an Oucher scale, and let me just show you. Various institutions have developed their own pain scoring system, and most of this is relevant to the post-operative period. That's where it's tested out the most. So this is the Oucher score. Okay, it's got the face of a little girl and in varying levels of distress. And this is the Wong-Baker FACES score. You're probably familiar with that. You've seen that around. So there's procedural rating scales, and again, the Children's Hospital of Eastern Ontario pain score to measure behavior. Let me see if I can get this. So this is the Children's Hospital of Eastern Ontario scoring system. So based on facial expression, verbalization, body position. So for a nonverbal or minimally verbal child who can't tell us what the pain score is, you can score them. Oh, this is really annoying. Okay, so this is a little about pharmacokinetics, particularly with respect to the neonate. Thing you should know is that protein binding is lower in the neonate. All right, particularly levels of albumin and alpha-1 acid glycoprotein. There's a decreased affinity of fetal albumin compared to adult albumin. And there's endogenous competitors. For example, bilirubin, in the first month of life, when kids get jaundiced, competes for albumin. So what does that mean? That means that the local anesthetics, particularly the esters, are less protein bound. And increased free fraction of local anesthetics means there's an increased risk of toxicity. Okay, so that's the important thing. They have lower protein, proteins that bind local anesthetics. There's a decreased affinity. There's competitors endogenous. There's local anesthetics are less protein bound, and so there's an increased risk of toxicity. This is in neonates. Hopefully the titles will come out on the handouts or on the copy that you download. I'm sorry about that. I don't know what's wrong with this. Okay. Children, neonates have increased body water compared to adults. So the total body water, for example, of a newborn is 70% compared to 55% of the body weight in adults. The extracellular fluid is higher in newborns compared to adults. And so they have a larger volume of distribution. All right. Neonates and babies have immature hepatic enzymes. Okay. During the first few weeks of life, renal blood flow, GFR, tubular secretion is decreased compared to older children and adults. And in terms of renal clearance, when you compare it to adults, in premature infants and newborns, renal clearance is decreased. However, in toddlers and children, it's actually increased. That's why you can give them massive doses of things, and they doesn't seem to bother them. So for newborns and children less than 6 months, they have less than 50% of adult cholinesterase activity. So the ester local anesthetics are metabolized by plasma cholinesterases, right? So there's a prolonged effect of local anesthetics in kids less than 6 months of age. Okay. There's decreased protein binding, means increased free fraction of morphine. Okay. So there's more than a 2 times increase in half-life in infants less than a week of age. This gets very relevant in the neonatal ICU and NICUs. Morphine half-life, for example, in a newborn is 14 hours compared to 2 hours in children and adults. So the clearance increases as a function of conceptual age. So for some, a premature born at 30 weeks of age, won't have the clearance of a neonate till they're 37 weeks. Post-gestation, post-conception. So because of all these factors that we talked about, there's an increased risk of respiratory depression in kids less than a month of age. So if you're using opiates and anesthetics in that age group, a monitored setting is advised. Okay, so we used to put any 3-year-old we had on the morphine infusion in a monitored setting, at least for the first 24 hours until we got the dose right and observed them. So what we're going to talk about next is a little bit about neuropathic pain in children, headache, which isn't as uncommon as one might think, recurrent abdominal pain, which is a very interesting entity that you see in school-age children, some of the chronic arthritides in JRA, sickle pain, briefly, and a little bit about cancer pain. Is that it? Oh, finally I added on chest pain. I think there was a question about chest pain in one of the boards. I can't remember. Okay, so first case is a 14-year-old. I had this case a couple of years ago at Joint Disease. She's consulting a pain specialist for persistent pain in the left knee and leg, okay, making her very dysfunctional. She had a medial meniscus injury, but that was months ago, healed, and this was something new that started. So she actually pinpointed to the start of the pain as when she was in the theater and she was sitting next to somebody who knocked her knee. And that's when this whole horrible pain syndrome started. Apparently minor trauma, or very minor trauma. The pain's constant, tingling, sharp, worsens with activity, and the parents are both teachers. They're totally anxious and overly concerned. Okay, and her neuromuscular exam is normal. And to talk a little bit about neuropathic pain and chronic regional pain syndrome in children, associated with injury, dysfunction, or altered excitability of parts of the CNS or peripheral nervous system. Right? Post-amputation pain was originally described in the Civil War, all right, when they did all these amputations, because that's what they could do for these gunshot and cannonball injuries. It includes plexus injuries and plexopathy. Does anybody know what the most common plexus injury is in children? It's brachial plexus from birth, canal injury, from birth injury. You can see neuropathic pain in childhood cancer, and children do have chronic regional pain syndrome type 1 and 2. Okay. So this is a slide, sorry there's no title, of chronic regional pain syndrome, age distribution. So you can see when it's described in children, you know, the majority of are under age 15. As far as chronic regional pain in children, there's an overwhelming female preponderance, much more so than in the adults, right? The age of occurrence is usually greater than 9. It's rarely described in kids less than 6. And there's a clinical triad of sensory, autonomic, and motor findings. So you see allodynia, hyperalgesia, spontaneous burning pain, hyperpathia, which is an exaggerated response to a painful stimulus, sweating, edema, and trophic changes of the extremity involved, and maybe loss of active and passive motion, which is pain-related. So this is a little graph that compares CRIPS in children and adults. Okay. So you can see it's overwhelmingly occurs in the lower extremity in children, 6 to 8 to 1. Where in adults, if you've noticed your adult patients, it's not uncommon to have the upper extremity involved. Now, this is unexplainable because upper extremity injuries are very common in children. They fall off the monkey bars, the outstretched arm, they get Colles fractures of the wrist, they get supracondylar fractures of the elbow. So, and if you work any pediatric orthopedic service, these are very, very common injuries. So we don't know how to explain this preponderance of lower extremity occurrence. There's also a marked female preponderance, about 7 to 1, as opposed to the adults where it's moderately female predominance. The treatment in children tends to lean toward physical therapy, chronic behavioral training. We rarely do blocks, whereas the push with adults is always to do an early sympathetic block to help make the diagnosis as well. Again, the push the recommendation has been previously to do a timing of therapy as an early phase in adults. The difference, and the big difference that you should know about CRIPS in children is that most of the cases have near complete resolution of symptoms, as opposed to adults where the outcome is highly variable and this chronic disability is very common. Sorry, I just have to see what, oh, this is how do you make the diagnosis of CRIPS in children, whoops. It's a clinical, you have the clinical findings of allodynia, hyperalgesia. Nerve conduction studies can help differentiate large and medium fiber dysfunction from small fiber dysfunction. Bone scan can rule out an underlying osteo. We do the same things that we do in adults: asymmetry of the surface temperature, resting or evoked pseudomotor asymmetry, and finally, occasionally in teenagers, a sympathetic ganglion block.
Why is sympathetic block not the first line treatment for kids?
Well, it's quite invasive, all right, because even if you don't do it, if you do physical therapy, behavioral training, family therapy, psychotherapy, very often there's a distorted family dynamics, they get better. So why would you risk doing something invasive with possible side effects if the outcome historically and statistically is good, right? Right, so this is management of neuropathic pain in children. And it includes non-pharmacologic methods like cognitive behavioral biofeedback for teenagers, hypnosis, guided imagery. Pharmacologic management includes NSAIDs, tricyclics, anticonvulsants, and opioids. And the interventional techniques similar to the adults. This is the old one. Okay. All right, so this is a summary slide of chronic regional pain syndrome. What it is, what it causes, and how you return to function. So kind of a nice summary if you want to take a look at it. Prognosis. A high percentage of children will show excellent recovery using physical therapy and cognitive behavioral therapy. Okay, that's the difference in CRIPS in children versus adults.
Have there been, I don't know if you know this, but have there been studies that compare adults and children employing the same methods that kids use in terms of physical therapy, like intense physical therapy?
Well, I mean, I don't know that there's one, a study that's been designed with both adults and children. I haven't seen that. There have been outcome trials for pediatric CRIPS, and so if you compare those to something similar in adults, but no, I don't know of any study like that. The last one, big one that I know of, was reported in pediatrics in 2002, where they did a 6-week randomized comparison. Group A had physical therapy 3 times a week and cognitive behavioral once a week. Second group had a little bit less physical therapy. They measured pain, gait, stair climbing, did a psych inventory, autonomic signs and symptoms, and looked at pain and the functional status at the end of the study, at the end of 6 weeks. They had 28 patients. After 6 weeks, gait and stair climbing improved in both. There was no between-group differences in pain or motor function, and the pain scoring scale improved in both. What about sympathetic blockade? You asked the question about that in adolescents and children. We reserve it for patients with persistent pain and limb dysfunction after you do the physical therapy, cognitive behavioral, family therapy. One of the big names in pediatric pain at Children's Hospital, Philadelphia, Dr. Sherry, really emphasizes the importance.
Mention him because
right.
He does these amazing
right.
physical therapy trials.
Right. He really emphasizes the importance of psychotherapy and psychological evaluation in these families. The case I presented, had a very, very involved. This was their only child. They were both teachers. They were highly anxious. They were taking notes about everything she did. So, he really emphasizes that family therapy is very important for these patients. There is a report of a prospective control trial of lumbar sympathetic blockade, the results of which were that most patients improved during the hospitalization. There was a small subgroup who had improved limb function but no improvement in pain. And they noted 2 anomalous responses in the children that they studied, which was a marked right shift in the dose-response curve of local anesthetics and undiminished pain despite a dense sensory loss, which is sort of interesting. And again, I think highlights the importance of psychotherapy in some of these kids. Okay, next topic is a 10-year-old boy with a headache. It's several months in duration. It's frontal in location. It's squeezing. He's vomiting. He's got frequent school absences, which of course is the important functional indicator in children. Past medical history and birth history is unremarkable. He's got a normal physical exam. He's normotensive for age, and his neurologic exam is normal. So what are the possibilities? Now this, I wish I had the animation, because this was good. The frequency of occasional headache in a child increases with age. Recurrent headache can occur in up to 10 to 20% of kids less than 10. And it's not something we think of as a disease of children, but it's actually pretty frequent. Migraine can occur in 3 or to 7% of prepubertal children. It's more common in girls at puberty. The incidence in adolescent girls is 10 to 27%. Incidence a little bit lower in boys. And tension headache accounts for a significant proportion of non-migraine headaches. This is a little laundry list of all the possible etiologies of pediatric headaches. So there's migraine and tension headaches, just as in adults. Psychogenic, of course, we have to put in there. Refractive errors. Your patients with orthodontic devices, for example, they use a retainer at night, wake up with a headache or pain around the head. It's important to ask about that. Sinusitis, raised intracranial pressure. Of course, I trained at NYU, so any child who comes in a headache, I think immediately of a posterior fossa tumor, but it's actually not that common. Epilepsy, drugs, sleep apnea. We have drugs again there. Okay. Hypertension is actually very rare in children, and certainly rare as a cause of headache. Migraine diagnostic criteria were done. They are similar to the diagnostic criteria for adults, so that the history and physical neuro exam do not suggest another type of headache, and other type of headaches are ruled out by appropriate investigations. So migraine attacks do not occur in close temporal relationship to another disorder. So a patient who has the flu or something like that in conjunction with the headache. And for migraine without aura, you need to have 5 attacks lasting 4 to 72 hours. It has to be unilateral, pulsating, moderate to severe, and aggravated by physical activity. And there can be nausea, vomiting, or phonophobia. With aura, you can meet the diagnostic criteria with only 2 attacks. The aura symptoms have to be fully reversible, develop gradually, and last less than 60 minutes. The headache follows the aura. The big question always in pediatric practice is, you have a child with a headache, when do you get imaging? Particularly for young children, it's not quite as simple as getting imaging in adults, because many of these children need conscious sedation or more, unconscious sedation. So you really need to be conservative in who you image. Any kid who comes in with a headache who's less than 5 should probably get a CAT scan. An early morning headache with vomiting suggestive of raised intracranial pressure, that's an indication for imaging. Any alteration of consciousness, a headache worsened by exercise or Valsalva, behavioral changes. Any kid with an open fontanelle who has an enlarging head circumference, although most kids in that age group wouldn't complain of a headache, they're infants. And then growth or developmental delay that's associated with it. Treatment can be symptomatic or prophylactic. There's not a lot of info on prophylactic treatment in children. Symptomatic can be NSAIDs, Tylenol. There are several studies in children on sumatriptan, and it's generally considered safe in the 12 to 17 year age group. Flunazarine has been found to be efficacious. Cyproheptadine, bivalproate, amitriptyline, there's not a lot of data on. There's conflicting data on propranolol versus trazodone. And there's not a lot on antiemetic use in children, because vomiting can be a big feature of migraine. So there's no controlled trials on Reglan or Compazine. There's, again, in terms of sumatriptan, there's one study from a long time ago that shows no demonstrated difference to placebo in the oral use. Positive results with intranasal use, and the subcutaneous dose is 0.06 milligrams per kilogram. Prophylactic treatment would be indicated for long, incapacitating, or frequent attacks. There's multiple studies. The prophylactic treatment is not overall very effective in children. There's no single drug that's been identified. The first-line agents, despite the lack of controlled trials, seems to be the tricyclics. We have a lot of experience with tricyclics in children. We use it for enuresis. So we don't lack that experience in the discipline. All right, just to talk a little bit about recurrent abdominal pain. I have a case of an 11-year-old who 2 to 3 times per week has an episode of abdominal pain that lasts an hour or two. It's mid-abdominal. There's no nausea, no vomiting, no other symptoms related to the GI tract. Physical exam might show mild diffuse abdominal tenderness, normal CBC with a comprehensive metabolic panel. The amylase lipase is normal, and an ultrasound shows no abnormalities. We used to see this kind of thing a lot in the emergency room. This is just a big list of all the causes of abdominal pain in children. You might want to just take a look at it and what the diagnostic approach is. I'm not going to go through this now. So there's everything from the common to the more unusual, like porphyria and familial Mediterranean fever, which can be associated with abdominal pain. So recurrent abdominal pain, RAP, is something that occurs at least once a month for 3 months, and with pain-free periods. Was first described in 1975. And the prevalence can be 10 to 15% of school-age children. It can coexist with other types of recurrent pain, and the title for many years was functional abdominal pain, implying we can't find a cause for it. It occurs usually 2 to 4 times per week. It lasts a relatively short period. It's periumbilical, can be epigastric, described as cramping, dull, sharp. There can be nausea and some vomiting. There's no sleep disruption, but it can interfere with normal activity, namely school. The physical exam may be negative or may show abdominal tenderness, and it really is a diagnosis of exclusion. If you look at that list, the earlier list. 10% of kids who present with this type of picture do have organic disease, and it's mostly referable to the GI or the GU systems. Okay, so it's a urinary tract infection or an inflammatory bowel disease or something like that. There's been a lot of, we don't really know what the cause is. There's been a lot of putative causes postulated, from lactose intolerance to carbohydrate malabsorption. One proposal was that it's a H. pylori infection, which is a 3 to 10% incidence in developing countries, but we don't have a high incidence of it here, and we certainly see a lot of recurrent abdominal pain. So, what signs and symptoms suggest that maybe this isn't a functional abdominal pain, and there's some organic pathology? Well, we need to question about weight loss, fevers, anemia, dysuria, localized pain that's far from the umbilicus, pain that may awaken the child from sleep, and certainly an elevated SED rate suggestive of inflammatory condition. And it's just treatment is generally biobehavioral, with cognitive behavioral strategies, stress management, biofeedback, add some fiber to the diet. Oops, okay, so now we're starting this. I think I missed one somehow. No, okay. So this is a rash. It's reticulated red rash. It's a 12-year-old girl who has chronic arthritis. Onset was age 2. characterized by periods of fever, rash, multiple swollen joints, continued exacerbation of arthritis, and bilateral knee pain. These are some subcutaneous nodules you might see. JRA affects about 250,000 children in the U.S. It can be, there's a number of different types. It can be systemic, like the one we described, with fever, multiple joints, almost a picture that looks like septicemia. It can be polyarticular or porsiarticular, meaning a few joints involved versus a lot of joints involved. Juvenile spondyloarthropathies include things like ankylosing spondylitis, reactive arthropathy. The most common cause of reactive arthropathy in children is parvovirus. So kids get infected with a parvovirus in the spring and then have weeks of a reactive arthropathy afterward. You make the diagnosis by getting parvovirus titers. But there are a number of others, certainly various types of venereal disease. Chlamydia can cause reactive arthropathy. Psoriatic arthritis is another cause. About up to 30% of patients with psoriasis may get concomitant arthritis. And then there's arthropathies that are associated with inflammatory bowel disease. There have been a lot of early studies on pain in children with JRA. And the bottom line is there's a significant incidence of pain. At 1 year, at 5-year follow-up, at just patients coming for their regular clinic visits, it can show there's a significant incidence of chronic pain in these children. Pharmacologic treatment generally is control of the underlying disease, right? And the pain intensity of the arthritis correlates with disease activity. So we can use NSAIDs. Gastric ulcers are relatively uncommon in children, certainly much less so than adults. Porphyria does occur in 12% of children, pseudoporphyria, that is findings consistent with porphyria that don't have elevated porphyrins. You know, porphyria is a defect in one of the heme synthesis molecules. And there's a fairly high incidence when you're using chronic naproxen therapy in children. And then in terms of the arthritis, there's remittive agents like methotrexate, hydroxychloroquine, and sulfasalazine. The newest one being etanercept. Steroid use, bursts of steroids are also used. This is Enbrel or etanercept, which is used by the rheumatologist. Etanercept works via the inhibiting or antagonizing tumor necrosis factor, and that's the mechanism of operation for its use in JRA, or just chronic arthritides in general. A little bit about musculoskeletal pain. The important things to know about is that there are episodes of transient arthritis, again, reactive arthritis in children. There's a entity called transient hip synovitis or toxic synovitis. We don't know what causes it, but generally presents in a 4 or 5-year-old boy with a limp who doesn't have septic arthritis. If it's really severe, the orthopedist likes to put these kids in traction. But it passes and it's ultimately benign, and a diagnosis of exclusion. Neoplasms obviously can cause musculoskeletal pain, some of the rhabdosarcomas and the osteosarcomas. And then idiopathic, growing pains. Generally in the limbs, lower extremities, even upper extremities, not really associated with growth spurts, as some of the earlier textbooks would say. So this is a chromatography of a blood sample. And it's a 14-year-old boy with sickle cell disease who has frequent painful crises. He's been hospitalized every 4 to 6 weeks for these crises. He's totally pain-free in between the episodes. And he uses oxycodone PRN at home when the crises start. That's really weird. This is an overall slide of the consequences of sickle cell disease. So you have a change in one base pair of the DNA molecule. Valine produced instead of glutamic acid at the position in 6 in the beta chain, right? And you end up with an abnormal hemoglobin molecule, which causes a change in the surface tension of the red blood cell, and they sickle. When these cells are destroyed, it causes an anemia, which then causes the bone marrow to proliferate, and you get weakness and lassitude from the anemia, impaired mental function, slow physical development. A lot of these kids who have serious, severe crises are small for their age, failure to thrive. And you get with chronic anemia, you get an enlarged heart. The clumping of the sickle cells interferes with circulation, so you get impaired blood supply to various organs, damage to the heart muscle, resulting in heart failure. You can get pneumonias, rheumatic features, paralysis from strokes and that sort of thing, and chronic abdominal pain, kidney failure. When sickle cells concentrate in the spleen, because that's what destroys abnormal things, you get an enlarged spleen and eventually autoinfarct, and so you have no splenic function. And this is the sickling of the red cells, the normal cell, and sickling. Pain in sickle cell disease can be extremely variable in timing, location, intensity. The duration of these painful crises tend to be shorter in children than adults. But there are children who may have baseline daily pain, just like adults with sickle disease. It's generally nociceptive in nature. Neuropathic syndromes are unusual. Severity can be anywhere from mild to intense. Some of the descriptions have been body chewing, body biting, beaten up, and it's been described as more severe than some postoperative pain. Can involve any part of the body, but the flat and the long bones are often involved, soft tissue, joints. And the pain may actually migrate during an episode. It may start out in the hips or back and then migrate elsewhere during the crisis. The thing to figure out when you're faced with this, is this a typical vaso-occlusive crisis, or is it another process? So anybody who has pain in the head, chest, abdomen, or limbs, you need to think of other processes. Does this patient have a stroke? Does this patient have a pneumonia with an acute chest syndrome? Is there, patients with sickle disease can get appendicitis. It's one of these areas where you have to be vigilant clinically. Differential diagnosis, of course, can include with head pain, a stroke, acute chest syndrome, which is life-threatening, needs exchange transfusion, cholecystitis, PID, appendicitis, and osteomyelitis, trauma, or AVN if pain involves the extremities. Infections can be rapidly fatal. These patients, particularly when they're older, don't have spleens. So any encapsulated organism can overwhelmingly infect them. And the question I always ask a patient is this what your typical crisis feels like? Is this the same as the last crisis, or is it different? And if it's different, how is it different? Sickle pain's a continuum. We try to manage it at home. Patients very often end up in the hospital. We use the World Health Organization stepwise approach. Pharmacologic agents include NSAIDs and opioids. And there's the World Health Organization, in case you haven't seen that before. Mild to moderate pain, NSAIDs and acetaminophen may be indicated. What the role is in vaso-occlusive pain for NSAIDs is unclear. Parenteral NSAIDs show variable efficacy, and one always needs to worry about analgesic nephropathy in these patients who may have compromised kidney function to begin with. Mild to moderate pain, we move on to the opiates, codeine, oxycodone, morphine, or Dilaudid. For severe pain, we may even consider methadone in children. You must have run across patients who absolutely insist on having Demerol, that the only thing that relieves their pain is Demerol. And I must tell you, years ago, that was the standard of care for patients in sickle crisis, that they would get every 4-hour injections of Demerol. They were intramuscular injections. And then the studies came about normoperidine causing seizures. It's a metabolite, has no analgesic properties, and can cause hallucinations or seizures. So again, a Demerol in a single dose is probably okay, but it's the repeated doses that become a problem when this metabolite builds up. But the truth is, these patients who are now in their 40s and 50s and older, this was the standard. So you know, we sort of taught them that they want Demerol, and so this is why you get these kind of requests. There's no published data about tricyclics or anticonvulsants. Hydroxyurea increases fetal hemoglobin, and there's been a decreased incidence of crises and acute chest syndrome in patients treated with it. Steroids come in and out of favor. Epidural analgesia has been used in crisis in children. This is the next case. Let me just present the case. It's a 16-year-old girl whose status post above the knee amputation of the left leg for an osteogenic sarcoma. Is having continued pain at the amputation site, which is interfering in a rehab program. So this slide shows cancer incidence for children under 20 by type, which includes germ cell tumors, soft tissue sarcomas, malignant bone tumors, neuroblastoma, a Wilms tumor, which is a tumor of the kidney, and hepatoblastomas. Cancer pain in children can be disease-related or treatment-related. Okay. We see bone pain in metastatic disease and the leukemias, somatic pain with osteosarcomas and rhabdosarcomas, visceral pain in something like liver cancer, and neuropathic pain can be seen in neuroblastomas and Ewing's sarcoma of the spine. Treatment-related pain includes mucositis related to chemotherapy, extravasation of the chemotherapy agent, and subsequent neuropathy in relation to the chemotherapy. Radiation therapy, you know, can cause mucositis, local tissue damage. We can see phantom limb in postoperative amputations, immune graft versus host disease, and finally postoperative pain if there's surgery involved. Procedure-related pain can be simply insertion of an intravenous line or port access. Bone marrow aspiration and biopsies are common in management of leukemia. Lumbar puncture for intrathecal medication, central line removal, diagnostic procedures, and then finally chronic pain in cancer survivors. A mucositis related to cancer treatment, there's not an optimal therapy for established. There's no single agent identified. Saline, opioids, sodium bicarb, mouthwash rinses, hydrogen peroxide, sucralfate, clotrimazole have been used, and parenteral opioids in severe mucositis. We have heard of magic mouthwash. You're familiar with this? Okay, it differs by institution what's actually in it, but generally contains a local anesthetic, a little Benadryl, some antacid, and some sort of flavoring. Antineoplastic related pain can be the local pain of thrombophlebitis from the chemotherapy agent. Intrathecal therapy can cause arachnoiditis and a meningeal irritation syndrome. Vincristine, the anthracycline antineoplastic agents, and actinomycin can cause severe local reactions, tissue necrosis. There's a peripheral neuropathy associated with vincristine therapy. It's a painful vincristine neuropathy. So sometimes it's important, if you get that symptom, to find out what agents the patient was treated with. Antiganglioside agents can have been known to cause severe abdominal and limb pain in children. That's monoclonal antibody for neuroblastoma treatment. And some of the salutary therapies, like the granulocyte stimulating factor, have been known to precipitate bone pain. Pharmacotherapy of cancer pain includes acetaminophen. Hepatic and renal injury is uncommon in therapeutic doses, but it does have an antipyretic action, which is important to realize in your neutropenic patients, where fever is important to know about. NSAIDs can be used if there's adequate platelet and function. We shouldn't use them in thrombocytopenic patients, and there's no safety or efficacy data on the COX-2 inhibitors in children. The opioids, in terms of oxycodone, and the problem with children is that the extended release forms, with the exception of Cadian and methadone, have to be swallowed intact. And many children, even into adolescence, have problems swallowing pills. There's higher clearance values, shorter half-lives in the ages 2 to 20 years for things like oxycodone. We use morphine with caution in renal insufficiency. And remember that morphine clearance is delayed in the first 3 months of life, and we reduce the dose by 25 to 50%. Same ratio as in adults. And if you need a sustained release morphine, one of the things you consider is Cadian, because you can open up the capsule and put the little sprinkles in applesauce. There's several studies on Dilaudid in children with cancer. The ratio parenteral to oral, oral to parenteral is about 6 to 1. But we don't know much about it in infants and children in terms of pharmacokinetics. Fentanyl, remember, has a high lipid solubility. The half-life is prolonged also in preterm infants, but similar to adults after the first few months of life. This oral transmucosal route's been used for procedures like lumbar punctures. The one thing about the oral transmucosal route in children is that there's a very high incidence of vomiting, up to 25%. So if you're going to use that for sedative analgesia, know that the patient may actually vomit. Meperidine is mainly used for rigors these days, as opposed to pain relief. We know that methadone's half-life is long, variable, and it gives an equivalent but more prolonged analgesia than morphine. And with children, as in adults, there's a risk of delayed sedation, so one needs to escalate doses cautiously.
Say something about fevers and fentanyl.
I didn't.
Oh yeah, would you?
I didn't.
Yeah.
Well, I mean, presume it's the same thing for adults, that these fentanyl patches can get enhanced absorption if you have fever. And children have fevers very frequently. So it's just one thing to consider. Antidepressants, in terms of pharmacotherapy of cancer pain, the data we take from adult studies, and again do baseline CBC chemistries and EKG. Psychostimulants have been used in children who are receiving opioids for cancer pain. Remember, we've been using psychostimulants in children for a long time in terms of treatment of attention deficit disorder, which we use Ritalin or something like that. So we do have experience with it. Corticosteroids may be helpful in children for bone pain or cerebral edema. Anticonvulsants we know have a proven efficacy for neuropathic pain with potential hematologic side effects. It has been gabapentin has been studied in children with phantom limb pain. Radionuclides, iodine-131, has been studied in metastatic neuroblastoma. Non-pharmacologic approaches are also very important. Physical approaches, massage therapy, heat and cold stimulation, TENS units. Behavioral techniques including relaxation and biofeedback, and finally cognitive techniques like distraction. So pain is a common symptom in children with cancer, and a multidisciplinary approach to treatment is really vital. Last night, this we'll do in a few minutes, chest pain in pediatrics. Chest pain you can see in all age groups. 50% of cases occur in children less than 12 years. When it occurs in very, very young children, you must consider an organic cause. Adolescents, it can be psychogenic. 7 to 36% of patients, pediatric patients who complain of chest pain have a chronic complaint, meaning it's going on for more than 6 months. What we're worried about is the cardiac causes, which maybe can occur in up to 15% of complaints of chest pain. There are structural abnormalities that can be associated with chest pain, like left ventricular outflow tract obstruction, even mitral valve prolapse. There are coronary artery anomalies that can give rise to chest pain. Acquired myocardial disease can happen after pericarditis, myocarditis, and coronary arteritis associated with Kawasaki's disease. Okay. And finally, dysrhythmias. I once had a 4-year-old come in and said, "There's a squirrel in my chest." And he had a supraventricular tachycardia. So it wasn't really painful, but it was uncomfortable, and he was sensing it. Musculoskeletal causes of chest pain in children, that's about 30% of cases. We see costochondritis. Tietze syndrome is an extreme form of costochondritis with swelling of the cartilage. Precordial catch syndrome, Texador's twinge. Do you know what that is? It's a syndrome where the patient takes a deep breath and gets a horrible stabbing, brief pain, usually on the left side of the chest. We believe it's neuromuscular. It actually can be overcome with some deep breathing. Doesn't have any clinical significance. It's a benign condition. Slipping rib syndrome, you know about that? The ribs 9, 10, 11, or 10, 11, 12 are actually not attached to the sternum, so they just have fibrous attachments behind, and so one of them can get a little bit loose and and cause that. Zoster can occur in children, and myofascial pain syndromes and fibromyalgia. So this just demonstrates costochondritis. It occurs in the area where the cartilage is attached to the sternum. And obviously pulmonary causes like respiratory disorders, cystic fibrosis, sickle cell anemia, asthma, foreign body aspiration. A kid who's jumping on the bed with a quarter in his mouth ends up in his airway. Pneumothorax, pulmonary embolism. We do see spontaneous pneumothorax in young men. And sometimes it's very small, and you have to look very carefully for it. And then there's the GI causes. That's pain that's referred to the chest, like esophagitis, foreign body ingestions, achalasia and hiatal hernia, and esophageal spasm or gastric distension. I think we'll stop here. This is a little bit about back pain. There's a couple of slides, and you can take a look at it on the handout if you want. So I'm going to give this to Taisha to put on the H drive. Okay. Thank you.